Hello, this is Dr. Huang with the UCR Video Library Series, and we'll be talking about childhood onset of obsessive compulsive disorder, or OCD. So our learning objectives will be 1. Define obsessive compulsive disorder, OCD. 2. Recognize clinical signs and symptoms of OCD. 3. Understand how OCD affects the child. And 4. Learn about the treatment and management of childhood OCD. So first, let's define OCD because there's a lot of misconceptions. It is not to be confused with obsessive compulsive personality disorder, or OCPD. The personality part is the different part. OCPD, which is often confused with OCD, that is what most people say, oh, you're very neat, you need things in order, you need things color-coded, you need things cataloged, you need things very clean. That is what we actually call in the medical field, in the psychiatric field, obsessive-compulsive personality disorder. So it's a rigid adherence to rules and regulations, an overwhelming need for order, unwillingness to yield or give responsibilities to others, and a sense of righteousness about the way things should be done. Oh, I need my desk organized exactly like this. OCD is different than OCPD, and we'll discuss why. So I like to think of someone with OCPD, which is what we're not going to talk about today, as someone who wants to color code their books. And what we'll talk about today, which is obsessive compulsive disorder, is a little bit different. And I'll explain to you why. So what is obsessive compulsive disorder? Well, there are two arms or two aspects of obsessive compulsive disorder. The first being the obsessions. So what are these obsessions? It's not simply like an OCPD. It's not simply that I need things to be the right way that they are. These obsessions are actually very intrusive thoughts, images, impulses, and urges that cause significant anxiety. They're not just excessive worries about realistic problems. In the adult, they might be, oh, I have this intrusive thoughts of I wanna hurt my family, or oh, I have this image in my head that just shows that my family's gonna die in a car accident. With children, it's some of these intrusive thoughts, they're a little bit more realistic. There, it's like, oh, my parents haven't been home, and they probably died in a car accident, or they have these impulses of why do I want to rip the head off of a doll, or why do I want to even can be physically distressing, like, oh, I have this urge to hurt myself. So that's the first component of obsessive compulsive disorder, which definitely distinguishes it from OCPD. It's these intrusive thoughts or obsessions. The second arm is the rituals or compulsions. These are either obvious or subtle actions that are aimed solely at reducing or eliminating the anxiety that is caused from having these obsessions or intrusive thoughts. This is, from a behavioral standpoint, it can take on very similar forms to that which you observe in OCPD. For example, like excessively cleaning something, or checking the lock 5 times to make sure that it's locked, and it can also be things like avoiding the mall, avoiding the car because you're afraid, or avoiding certain people. But the main differentiating factor between OCD and OCPD is that these rituals and compulsions, the reason why they're being conducted by the person or the patient or the child is that it's trying to reduce the stress from having these intrusive or obsessive thoughts. So like I said, it's characterized by obsessions or compulsions that are significantly impairing and distressing. It takes up more than 1 hour per day. So I've seen patients that check the lock 5 times, 20 times, just because it helps decrease their stress about the intrusive thoughts. I've seen people clean a doorknob for about 30 minutes, and it runs a chronic and unrelenting course, especially if left untreated. Your quality of life is kind of ruined with obsessive compulsive disorder. You have difficulty with school, you have difficulty in maintaining friendships, you have having family stress, and you really don't want to engage in enjoyable activities anymore because you're so under a lot of stress from these obsessions and intrusive thoughts. Misdiagnosis is very common. And as a result, you can have shame and guilt associated with the disorder. It's difficult to open up to anyone really about these symptoms, especially if you're having these maybe grotesque or inappropriate intrusive thoughts. So there is one nuance, though, that is for children that I want to make clear. I know previously before I mentioned that OCD is not simply excessive worries about realistic problems, and that's what we see in adults. These obsessions are, I think the plane is going to crash, or I think that someone's going to invade my home. They're not really found in evidence. But with children, it's interesting, at a young age, you don't really have a sense of what's real and what's not. And so they don't necessarily have to be exaggerated, because from the perspective of an outside person, you don't know if they think it's exaggerated or not. So really, having that exaggeratedness or unrealistic component of their obsessions really does not apply to children. So they can have obsessions about, I'm worried that my teacher is going to give me an F, and to us, that doesn't seem too exaggerated, but maybe to the child it does. And so we don't want to simply discredit any children having any realistic intrusive thoughts, because they don't necessarily have a frame of reference for what is real and what is not. So a little bit more about OCD. It affects 2 to 4% of the U.S. population. It is the 4th most common psychiatric disorder in the U.S., and I suspect it might be even higher because it's either misdiagnosed or missed even. It's typically, you start to see the symptoms of it in the late teens or early 20s, but and the average age of onset is 10 to 12 and a half years old. But there have been some cases where you can see it in children as early as 7 years old. And about 80% of adults who have OCD started having them when they were a child. And this is probably the most shocking thing right here, and the thing that we need to work on the most as providers, as parents, as just people who take care of children, is that the average time between when the symptoms start and when they're properly evaluated and treated is 17 years. So a child can start presenting with symptoms at the age of 10, and only until they're about 27 on average do they actually get treated for their condition. So they can live 17 years, they can go through 17 years of having social anxiety, shame and guilt. It's a very long time. So why is it so impairing? So mainly it's the second arm of OCD, which is the compulsions or the rituals, because it really takes a lot of time in your day. And it's really the process is what we call negative reinforcement. So you're doing something in hopes that something doesn't happen. So you're cleaning your doorknob 5 times, 10 times, 20 times, because you're worried that because it feels right, because if you do it 20 times, then you're worried about your child dying in a car accident, or you're worried about your mother not coming home goes away, or it gets helped. It's as a very gradual onset, and it starts to worsen over time. As you start cleaning things 20 times, your body gets used to it, your brain gets used to it, so maybe you start cleaning things 30 times or 40 times. And it definitely involves the entire family. When you have someone that is misdiagnosed or is not diagnosed with OCD, and the parents are wondering, or the siblings are wondering why the child is in distress and why are they acting this way, it can really impair the family as a whole. And not to mention, anything, as with most psychiatric disorders, if you have one, you're most likely to have another. Anxiety disorders are very common in the early adolescence, and 2 out of every 10 children will meet the criteria for anxiety during their entire life. And anxiety and depression are comorbid, or they very strongly go hand in hand with OCD. There are many subtypes of OCD. They're mainly to do with the rituals, some with the obsessions, but contamination washing. So like I said, maybe they really want something to be washed 20 times because it feels right, because it helps them not think of a intrusive or inappropriate thought. Maybe they're checking the oven to see if it's off 10 times, even though they know. And a lot of times the child or the patient knows that the oven is off, but they just feel compelled or that's why it's called a compulsion, to just check it. Maybe they want to put things in order, they need symmetry, maybe they hurt themselves, other many different subtypes. And then they can also have contamination obsessions. So this is the most common obsession in children. It's an obsession or intrusive thought that things are poisoned or things are contaminated, and so that's why they have to clean things, or that's why they have to order it the right way. Checking and counting is also common in children. They have to count, make sure that all their toys are in line and in order, and if not, then something bad's going to happen to mommy and daddy. And they may ritualize to prevent harm from befalling others, and that's what we see common in children. So what are the signs and symptoms that you want to look out for of OCD in children? Well, if you notice that they do frequent cleaning and hand washing, if their hands start to get to the point where they're red and chapped from just constantly scrubbing and constantly using soap, if they're having long and frequent trips to the bathroom, maybe they're flushing the toilet 5 times or 10 times. Maybe they don't want to go outside to the playground, or they want to avoid art supplies or sticky substances because they feel like it's contaminated. Another common key clue is that if they have untied shoelaces and they know it's untied and they don't want to untie it, because sometimes they can have an obsession where their shoelaces are contaminated and they don't want to touch it, and they do. They can, if they're checking stuff, sometimes they're known to hoard as well. If you notice that their desks are very messy and they're saving a lot of things. Maybe they're going over letters and numbers with a pencil. They're just writing the same letter over and over again when not asked to. Maybe they're just, and also you just also want to look at the behavioral stuff too. If they're just being depressed or anxious or not really engaging with their friends or their usual activities, then maybe something's the matter with them. So here are more signs of OCD in children. They have an excessive fear of bad things, just to reiterate. They have excessive fears of making mistakes. They're maybe late. That's a good one. If they're constantly late because they're doing their rituals and it's taking up too much time. Interestingly enough, I'd like to talk, there is some evidence of this, what we call PANDAS, or pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. Basically, if you have a strep infection as a child, you are prone to actually developing psychiatric disorders, and OCD is definitely one of them. Still not really well understood why children develop psychiatric disorders after a seemingly unrelated infection, but the evidence is there. So these children, the reason why they have these obsessions is they have these errors or in their thought, in their logic, in their reasoning. They start to have doubt. They start to have uncertainty. I can't remember if I checked my door lock. They have what we call thought-act fusion. They say, if I think about having sex with my cat, I must want to do it. Or they maybe overestimate the probability. I can get HIV from sitting on a public toilet seat. They might start to catastrophize things. I'll get sick and die if I go near sick people without washing afterwards. Or they have this sense of responsibility. If my mom develops cancer, it's my fault because I didn't check the doorknob 10 times that it was locked. So as you can see, you can end up with a very vicious cycle in the OCD cycle. I love this figure. It's a very good and accessible figure. So you have these intrusive memories, urges, impulses, images, ideas, sensations, all very intrusive. And what we mean by intrusive is that it just consumes the brain and and it distracts the child and doesn't allow them to really do anything else. Which leads to obsessions. They somehow, with their flawed logic, as we discussed here, they attach meaning to it. It causes a lot of distress. Then they start to do some compulsive behavior, and it can be completely unrelated. Like I said, they can feel that their shoelaces are contaminated and don't want to touch them, but then they'll clean the doorknob because they think that will help their shoelaces be not contaminated. It doesn't have to be related to their obsession and compulsion. Don't have to be related. So they'll do these rituals. They'll maybe avoid stuff. This will provide some temporary relief, and it causes a negative reinforcement in their mind, like, oh, my mom did not die because I cleaned the dishes 10 times over and over again. So therefore, I need to keep doing that. And then you have a vicious cycle, and as you keep going through the cycle, it gets worse and worse as it gets more negative reinforced and more strengthened, and it becomes difficult to treat. And you can see if it takes on average 17 years until the cycle gets treated or gets even detected, and that's a major concern. So what is the treatment for OCD? Well, the gold standard treatment is something called cognitive behavioral therapy with exposure and response prevention. This with exposure and response prevention is key. It's the first line treatment for children. Cognitive behavioral therapy alone is typically used only for children with OCD of moderate severity or less, but they start to incorporate exposure and response prevention, which we'll talk about in a bit, along with antidepressant medications if the case is more severe and the child is very impaired. It's a very well-documented treatment that's very effective. Nearly 90% of children who undergo this treatment respond very well, which makes it all important to detect these signs in children so that we can avoid and decrease that average time of 17 years for them to get treated. The treatments are all tailored to address their specific OCD symptoms and obsessions and compulsions. It helps externalize disorder from the child. Children don't know that about mental or medical illness. They start to think it's their fault, and it helps the child come to terms, and even the parents. It removes some of that shame, that guilt, that feeling of responsibility from the child, which helps relieve a lot of stress. And typically they tailor it towards children. They use metaphors, analogies, names like a brain hiccup or OCD monster to make it more accessible for children. So it's definitely both applicable for adults and children. So the exposure and response prevention. So this is something that's not in all cognitive behavioral therapies, but this is what's used for moderate to severe cases of children with OCD. And basically you're just trying to expose the child and trying to kind of typically expose them to what their fears are, putting them face to face with their fears so that they can face it. They can realize that it's not real or it's not as bad as they thought it would be, and then this kind of sets forth a better negative reinforcement where it's not influenced by the rituals, but more about reality and logic and their experience and exposure to those distressing thoughts and environments. So like I said, you induce a situation that causes significant anxiety, and you discourage the use of anxiety and by basically telling him, let's try to reduce the amount of cleaning that you do and let's see what happens. This enforces that it's okay to be stressed out, that your parents are not home. And that it's okay, that stress is not going to hurt you. What really does hurt you is when you engage in these rituals. And it weakens two associations through habituation or through repeated use. It weakens the association between the distressing thought and anxiety, so your thoughts become less distressing. And it weakens the association between the rituals and decreasing your anxiety. So you start to not associate cleaning the doorknob with calming you down anymore, and that helps a lot. So some main points and takeaways from working with children with OCD. You want to make the exposures fun. You want to use playtime. You want to make it very accessible to them. You want to coach them very encouragingly. You want to empower them to make their own decisions, to tell you how they feel. You want to also avoid excessive and unrealistic reassurance as well. Just temper their expectations. Their anxiety is not going to go all the way, so it's okay for them to feel a little bit anxious. So in summary, OCD, obsessive compulsive disorder, is defined as obsessions and or compulsions that are significantly impairing and distressing. It's typically onset is and starts to show during the childhood years, with an average age of onset of around 10 to 12 and a half year old. Like I said, it takes around on average 17 years for it to be treated. So what you want to look to prevent 17 years from going by in a child with OCD of not having any treatment or any intervention, you want to look for these signs and symptoms. You want to look for rituals or repetitive compulsive behaviors. You want to look for overcleaning, counting, hoarding, avoiding stressful situations. And once you are able to spot that and refer to that and make it known that, and raise questions about the patient possibly having OCD. If they do in fact have OCD, there's very good treatment for it. Cognitive behavioral therapy with exposure and response is the gold standard treatment, and 90% of children respond very well. And so you really can, by detecting it early and getting them to the right people, a psychiatrist, a pediatrician very early, you can really help improve that child's development and quality of life for the rest of their lives, really. Thank you.